So here we're going to talk about the gastric mucosa secretions that are important to avoid the stomach damaging itself with its corrosive secretions, and what happens when these um, protections then become defective. So the stomach has three mechanisms that prevents the epithelial cell layer from becoming digested by its own secretions. Um, the epithelial cells, they're not pH resistant on their own. There are mechanisms that protect it and allow the gastric epithelial cells to maintain a normal pH and a reasonably normal physiology. And this slide summarizes and illustrates the three components to that. First, there's this unstirred bicarbonate-rich mucus layer that maintains a pH of about 7 at the cell surface and protects the gastric mucosa from the much more acidic gastric juice, generally around pH 2. And it's a very thick mucus secretion that lines the entire surface of the stomach wall, and it's rich in bicarbonate, and as a result it forms a protective layer between the stomach lumen contents and the gastric epithelial cells. Not only that, but these epithelial cells are very tightly connected at the surface level. They have tight junctions between the gastric mucosal cells, and this prevents penetration of acid in between the cells, so that damage doesn't occur by excessive protonation. And then finally, the luminal membrane itself, the gastric mucosa cells, is impermeable to protons. And so this is the final barrier. So you have this protective mucus layer, you then have cells that are packed tightly together so protons can't get in the middle, in between them, and then the epithelial membrane itself is impermeable to protons, and this means then that the cells are protected from the acidic milieu in the stomach, and no damage can occur, and these cells can go on happily performing their functions. It does break down though, and peptic ulcer disease can be separated into two different types: gastric ulcers or duodenal ulcers. And the mechanisms involve either a hypersecretion of acid, i.e. a gastrin-producing tumor, gastrinoma, such as in Zollinger-Ellison syndrome, or the effectiveness of the gastric mucosal barrier can become impaired. This can happen through drugs like aspirin or non-steroidal inflammatory agents that can inhibit the secretion of mucus and bicarbonate, and then this prevents this initial layer from doing its job properly, and then the cells underneath get damaged. There are also stress ulcers. Chronic high levels of epinephrine, of sympathetic stimulation, can decrease the bicarbonate secretions, making this first mucus layer less effective, and then the cells underneath become damaged as a result. Stress ulcers are less common than they were once thought to be. That's because it was found that a large amount of ulcers are caused by an infection via Helicobacter pylori, which is we'll go into it in a second. But generally, if you don't get any acid production, you won't get an ulcer. I think it's worth pointing out here as well that duodenal ulcers are more common than gastric ulcers. The stomach has very powerful mechanisms to prevent acid damage, whereas the duodenum doesn't really have that much protections. It does have secretions that neutralize the acid that comes through. It doesn't really have this protective mucosal barrier, or these tight junctions that prevent acid damage. And generally, the duodenum is prevented from acid damage by regulating the flow of gastric contents into its lumen. H. pylori is a common infection of the stomach that leads to gastric ulcers, and it's a peculiar bacteria in that it grows effectively in acidic environments, and so it colonizes the stomach very well. And you can see here in this stain that there are colonies of H. pylori growing on the epithelial layer of the stomach, and it's found in 40% of the population. Many are unsymptomatic, but most patients with ulcers have them. And this seems to be the predominant cause of ulcers in people these days. So the bacterial secretion products evoke an immune response in the mucosa, and so what generally happens when people get infected with this stuff, first of all, is you have this chronic superficial gastritis, general inflammation that happens, and this reduces the effectiveness of the mucosal barrier, and then after a while of this happening, an ulcer will form, and if it's not treated, it increases the risk of a gastrinoma causing cancer. And so here are some slides that illustrate what happens during these infections. So here we have an endoscope of the pylorus, and you have this erosive antral gastritis forming superficial lesions on the mucosa. And then if this is allowed to progress, then you'll get this ulceration of the mucosa. That this one has penetrated all the way through to the muscularis mucosa. It's possible to have multiple ulcers. Here you can see ulceration at the top here, ulceration on the side. So this patient has two gastric ulcers, and it's possible for this ulceration to penetrate many layers of the stomach. Obviously, the gastrointestinal tract has 4 layers: the mucosa, the submucosa, the muscularis externa, and then the serosa on the outside. And the ulcer, if unchecked, will penetrate all the way through these layers. And so here we have a perforating gastric ulcer, where it's just eaten through the wall of the GI tract. And here we have examples of a duodenal ulcer compared to a gastric ulcer. And then you can also get multiple duodenal ulcers, similar to the gastric ulcers. And then, so this is a perforating duodenal ulcer, where the ulceration has gone all the way through the tissue and has exposed the GI tract to the peritoneal. And under these conditions, when you have a perforated ulcer, one classic sign of this happening is that air is seen underneath the diaphragm. And this is suggestive of a perforated ulcer because the lumen of the GI tract is exposed to the outside, and as you swallow, you'll bring in air. And if this is perforated now, if your GI tract is perforated below the level of the diaphragm, this will allow air into the peritoneum, and it will float to the top, and you'll get air under the diaphragm that is visible during X-rays. So the therapy for ulcers mainly caused by H. pylori, you would fight this by antibiotics. You want to reduce the acid production so that ulceration can heal. And obviously we talked about Prilosec in the gastric secretion video. And so Prilosec will inhibit the proton potassium ATPase, but you can also get H2 receptor antagonists like cimetidine. Antacids can neutralize the acidic contents of the stomach, and there are this was an old technique that's kind of fallen out of favor, but if you have a vaginotomy, you cut the vagus nerve to the stomach, this will reduce gastric acid secretions because it's under vagal control. But obviously this has side effects in that you cut that, you're going to lose signal to the motility of the stomach, and people who have vaginotomy will end up with motility issues that result from this fairly extreme method of treating excessive acid production. And then you can just eliminate other cause, i.e. stop taking aspirin or other non-steroidal anti-inflammatories, change your lifestyle choices so that you're not so stressed, etc.